Hi everyone, this is Mr. Neil Wright, also known as the Wax Whisperer. Thank you for tuning into my latest video. So for a patient who attended with bilateral, extremely hard and dark coals of earwax, they actually look like pieces of coals. And we're just in the left ear here, just starting off using a Zollner suction probe, so we call this microsuction. Managed to get the outer lateral piece of this hard earwax out using suction. Now this is just beyond the second bend, so around 1 centimetre into the ear canal. And we're just going to be careful here not to inadvertently push this hard piece of wax further in the ear. When you've got a solid piece of wax like this, sometimes it is difficult to get a suction grip. And what can happen, the specialist, in an attempt to try to suction this, can push the wax further into the ear using the tip of the suction probe. So you're going to be really, really gentle. And what I'm looking for here, I'm just looking for a really delicate suction grip. So I'm just hovering over this piece of wax, and any bit of suction I'm getting, I'm just trying to cling on to that, as opposed to pushing the suction probe deep into the wax, which will just push this further in the ear. So this wax is more or less mobilized. It is loose in the ear. It's not really, I would say, attached to the ear canal wall, but it's just a matter of maneuvering this forward slowly. And you can see I'm bringing it forwards, but as I'm bringing it past this second bend, because of the curvature and at the second bend we have an isthmus and narrowing, it just gets lodged here. So it's not coming any further with suction. So I think in a moment I'm going to try and use some forceps to see if I can grasp onto the bottom of this wax and bring it forwards. Here we are. So I'm just trying to get the jaws in between the plug of wax at the base. You can see there's a few hairs here, it's slightly matted. I've managed to get a grip, but I'm bringing it forwards, but it's still lodged. It's not coming beyond this second bend. Therefore, I'm going to resort to an ear hook in a moment. And we're going to use the ear hook to prise this hard stone-like piece of wax out of the ear. So I'm just at the roof of the ear canal, the superior part, just gliding the ear hook in and behind and slowly rotating the hook to lever this. So that's what we're doing, kind of almost levering this plug of wax forwards. So we're just past the second bend here. You can see the anterior canal wall just to the left. And I'm in and behind, and I'm just really levering this forward. You can see you've got a large piece of wax out there. So this has been in the patient's ear for a number of years. You can tell by the colour it's oxidised. The patient has got a bit of mild psoriasis, eczema, or otitis externa, whatever you want to call it, at the entrance of the ear canal. They had been getting water in the ears, so I've advised them to avoid that. So just rotating the hook on the posterior canal wall. So I'm gliding it to the posterior canal wall, rotating the hook clockwise into the wax. And as I rotate this ear hook, it naturally brings the wax forwards. Again, just targeting the posterior canal wall. You can see a bit of keratin where I am now, deep in the ear. So this has attached itself to the wax and to the plug of to the wax and also the canal wall. You'll see where this keratin came off. So you can see here some keratin at the base. That's where the wax plug was attached to. So I'm just using a bit of suction here. I'm going to use a fine end. I'm going to be really careful it doesn't clarinet. Clarinetting, when the skin, when you suction it, it violently flaps at the tip of the suction probe, and it emits a very loud high frequency squeal. So you want to avoid that wherever possible. So I'm going to attach the fine end. A fine end gauge is an extension to the standard Zollner suction probe. It's a narrower suction tip, so it's less power, but however, you're less likely to get clarinetting. So just slowly lifting this keratin off the base of the ear canal. We're quite deep in the ear, so this is the isthmus. This is the second narrowing in the ear. It's about 0.5 centimetre away from the patient's eardrum. It's got some dead keratin on the posterior canal wall. We're not trying to get every little last speck of skin. We could have actually left it as it was. If I'm training some of my clear wax delegates, I would have said, look, just leave this for now. It's not going to cause a problem. But when you're confident and the patient's really still, wherever possible, with this kind of skin, sometimes it doesn't migrate out the ear naturally. So we just give it a little helping hand. Just a bit of dead skin on the anterior canal wall. And that's the patient's left ear done. So it's going to mop up near the entrance with a bit of dry skin flakes. even from this distance, we can see the patient's eardrum, and the endoscope's not actually in the ear. So we've got a nice, beautiful view of the patient's tympanic membrane, a light reflex in the correct position, south western in the case of the left ear. So this is the patient's right ear. Immediately went in with an ear hook. This wax is a lot harder and firmer. There's a gap at the top. And I'm just rotating the hook in. I want to get some purchase. So I'm rotating it clockwise, trying to embed the tip of the ear hook into this core of the wax. I'm now going down and stabbing it in and trying to bring it forwards. But it's so hard, it's just breaking into little pieces. But slowly but surely, we're just bringing this forwards. So we're just near the patient's first bend of the ear canal here. Just gliding this hook on the posterior canal wall, the back part. So I actually then rotate this anti-clockwise. So you want the tip of the hook to go away from the canal. Otherwise you'll poke into the canal, it'll be very uncomfortable. You see it's just lodged at the entrance here. Slowly but surely. And this piece of wax, when I lifted it with my glove and put it on the tissue on my medical trolley, it made a real loud ping, it's almost like a stone. Just some dead keratin at the base. Just using a fine end. I think it was clarinetting, so I just stopped at this stage. Just leave that there because it was clarinetting. We don't want to expose the patient to any unnecessary loud sounds. It's just a bit of keratin at the top. So again, this is a bit softer. So I'm just gliding the fine end over the roof of the ear canal, just to glide this away. There was no clarinetting here, so I just removed it. And again, we've got a fantastic view of the patient's eardrum. The endoscope's only just in the ear. We can see the cilia there, the hair's just protruding on the left-hand side. So that's around the first bend of the ear canal, about 2 centimetres away. We're actually out of the ear canal now. And then from here, you can see the eardrum. So again, the patient's got a bit of mild psoriasis, eczema at the entrance of the ear canal. So advise some treatment for that. You're going to weighed it all, so 667 milligrams. So over half a gram. And in a moment, you're going to see a close-up of the coals of earwax. So I got the endoscope and just hovered over, so you can see the consistency, the texture, the roughness as well. You can see it's quite a rough outer surface. It's like an asteroid. Think about Armageddon. Some of these pieces look like that huge meteorite going to Earth. In fact, I'll use that as my thumbnail, I think. Meteorites of earwax removal. Take care.